I'm a GP from dry and sunny Manchester, where it was actually dry and sunny this morning, amazingly. Our practice is in Moss Side and Rusholme in central Manchester. But I also work part-time at NHS England as the Head of General Practice Development. And what that means in practice is that I'm partly responsible for helping to imagine the future, mostly through listening to what other people are already doing in terms of their future and their vision for the future. Be the voice of the reality of general practice into some national policy and strategy making. But also, most of my time is spent actually thinking about how we're going to get there. So things like the 5-year forward view, I had the chance to contribute to that in terms of describing an attractive vision of the future of the NHS, but also then the general practice forward view was largely about the how we can help right now. And I'm going to talk a bit about both of those. I've had the privilege of doing lots of stuff to do with whole systems thinking and whole system strategy and design, done a lot of work with integrated care over the years, both in this country and in a number of other countries. But actually, I'm going to start very much and locate virtually all of what I say in the world of general practice. I know a lot of us are here from general practice, many people are here from outside, and I hope you'll forgive us from starting with ourselves. I hope we're going to start from in ourselves in a way that kind of does actually reach out a bit. And I'm going to reference stuff like, as people have just been talking about the general practice forward view and things like that, really happy to, if I can answer any questions about that, as well as other stuff you may want to chat about, really happy to do that. We're going to make the slides available as well, and I always put my contact details up here. If you're a member of the Twitterati, please do feel free to be tweeting away at Robert Varnam. But I put my contact details on there really because a lot of my usefulness comes from me knowing what the reality is around the country, knowing what you're working on and what gets in the way of making progress. And so, I mean it, please do feel free to contact me. So I'd like to sort of reflect on some of the top questions people are asking in general practice right now, and some of the things that actually I think we've been asking for a few years, really. And to start putting what I see as potentially some useful detail on well, what specifically could it look like for us? And I know some of the situations, some of the plans that you've been looking at as a group of practices and a wider health economy in Bristol. So I hope this is useful for you, as well as just sort of interesting. Is this, people sitting over here, is this thing in the way? Is it all right? Lovely, okay, fine. So I'll leave it there, shout if it does get in the way. So here are the top questions that I get asked. One set of them is all from the world of, we're setting up a federation. And people have a lot of questions about that. What size should we be? What structure or legal entity? Or the ones where people phone me or kind of meet me and say, we're a federation, now what? And I think that's probably one of the most challenging or one of the most common ones. I think I'm going to suggest that actually they're pretty big red herrings. I think that's because we fall into the trap too often in the NHS, for obvious reasons, of talking about structure before purpose, or talking about form before function, or talking about the business before our patients. And it's understandable, but I think it's wrong. And I'm going to say I think it's wrong. I think there's a second set of questions people ask a lot, which I think are probably more useful or more helpful to start with. And they come from people saying, why is everyone talking about change at the moment? And it may be that you're at one side of the equation or the other side of the equation, but I think the equation is people are talking about change everywhere, and it's not just in this country, for some really interesting reasons. Either because of some really big and important pressures at the moment, or some really big and important opportunities at the moment. And I know actually for Bristol practices and your partners, you've been looking at both the pressures and the opportunities, and I think they're reflected, that thinking, that reality is reflected in the strategy that we just heard. And that thinking particularly about the pressures is the reason why we commissioned last year the Making Time in General Practice report. There's been a growing cry of pain from general practice over recent years. And what's been really tricky for me, I started work at NHS England a couple of years ago, and part of my purpose, part of the reason why I said yes, was that I felt this growing cry of pain from practices. Lots of ambition, lots of commitment, lots of talent and all the rest of it, but this growing angst. And what was really difficult for me was realising how nationally and centrally that tends to be heard as just a morass of undifferentiated and politicians in particular get used to hearing that from people who work everywhere, public sector, private sector. You know, they meet with the banking lobby, it's they meet with people in pharma, it's meet with people from the public sector, it's and they get used to just saying, well, that's normal, isn't it? And therefore we don't really need to do very much about it. And I felt that actually, if we put some numbers on this, we might be able to move past this belief that it's just people moaning. And so we did two things. And if you haven't had a chance to read this, if you just Google Making Time in General Practice, you'll find this report. There's some really, really good resources on the Primary Care Foundation's website to sort of back it up. But here's what we did, very, very quick sort of view of what we did. First of all, we did a survey of practice managers and an audit of consultations, and then we did some qualitative work trying to understand what that meant, and then we got a lot of the great and the good from general practice together to say, well, what does this mean, and what should we do about it? And here's what we found. First of all, in the area of bureaucracy, so things that the system puts onto us in terms of workload, these 5 came out as the top areas, the most burdensome areas of bureaucracy. They're big, they account for a huge proportion of the time of practice managers and their teams, and practice managers told us all of them were rising, and some of them were particularly new, like getting paid always was a bit of an issue, but then when you move to being commissioned by NHS England and a CCG and a local authority, and sometimes more than one local authority, the complexity goes haywire and people are left spending, in some cases, very large amounts of time each month doing stuff like reconciling a bank statement and working out what the heck that means. So very, very basic things taking up a huge amount of time. It's not about delivering better care for patients. It's nothing to do with clinical care or running a great team. It's things that the system puts on us. Really interesting at the bottom, about 7% of non-clinical time being spent by practices helping patients navigate the health and care system. And they said that's rising one of the fastest. Interesting, hold that thought. Let's look then about what GPs said about their own workload. So GPs were asked to do a little audit. At the end of the consultation, you were asked very quickly, do you think there might have been an alternative way this appointment could have been handled? So was this a potentially avoidable appointment today? Just over 5,000 consultations were audited, and here's the staggering result. About a quarter of those appointments were judged by the GP in the moment to have been potentially avoidable. That's a pretty shocking fact. That statistic has caused people nationally to sit up and listen and look differently at what we do. If you sort of categorise it a little bit, what you see is that some of these things, these orange things, like outpatient work and sick notes or appeals, where the GP knew there was no valid input for a GP opinion. We all know what those sort of situations are like. These are things which are completely outside the control of the practice. 4% of appointments with the GP are being generated by some sort of lapse in outpatient care. So I was meant to have my follow-up appointment after the MR scan in March, and it's now May and nothing's come through. Book an appointment with a GP. Or seen in outpatients, you're going to need this prescription, off you go. Hospital pharmacy says, we don't stock that. Or you're going to need an ultrasound and some bloods, and then we'll need to repeat your bloods in 3 months. Please ask your GP to do the ultrasound and the bloods, those sort of things. And then this 3% that come from appeals where we know nothing can be done by us. But what's really interesting is the things in green are not external. They're not about failures in the system or changes in the system. They're mostly to do with us and our immediate environs, really. So 7% of the time, the GP said this really could have gone to someone else in the practice. 6% of the time said this really could have been better dealt with by self-care, supported by the pharmacy. 3% were really just to do with decisions and navigating through the system. And 2% shouldn't have been with me, it should have been with a different GP, or should have been with me, but only after we got the result. And if you sort of translate that into what that mean, those percentages mean nationally, millions is the answer. This one here, this 8 million block here, is what caused the Secretary of State to really get very agitated and change the NHS standard contract for this year, so that now no hospital can operate a blanket policy where a patient who DNAs has to be re-referred by the practice. This new thing about having to have 2 weeks grace for the patient to be able to rebook. It wasn't an instant thing, but it took only about 4 days for that decision to be confirmed, which is record time. But if you think about the impact at a local level, just on a kind of a typical practice, so if you translate that to a 6,700 patient practice, it's thousands of appointments a year could potentially be handled differently. And I think what's really interesting about that is that it starts to move us from this general to actually there are some specific issues here. And as soon as you start listing them, you start seeing some specific solutions. I'm going to describe what some of them are in a moment. And so it's already been really helpful. And if you were one of the practice managers who contributed or one of the GPs, thank you. You've changed the country already. So that's great. But there's something else. I said there's a lot about pressures and some opportunities. There's something else about it, which is not about government policy or NHS commissioning or bureaucracy. It's actually to do with the people we serve. And I think it's important because it's not going to go away. And I think also it's important because it points to some hopefulness as well. So I don't know if you've seen this data already. This is from originally the Scottish School of Primary Care, but it's been reproduced many times over, all over the developed world. It's not just us in England who are asking these questions. What it shows, very simply, is this. As you get older, the number of long-term conditions we have, or the likelihood that you'll have a long-term condition, goes up. And as we know, the proportion of people with multiple long-term conditions is going up particularly quickly. And so if you look at people aged 75, about a third or more have 4 or more long-term conditions. Now, why is that particularly important? I think it's really important for us all to get our heads around this. This speaks about a need that the NHS was not really designed for. Fundamentally, the assumption underlying the way we set ourselves up in 1948 was that from time to time someone would get ill, they would come to see their GP, who'd give them a cure, and after a week or 2, they'd go back to normal life. And at some later date, they might need to come and use the NHS again, and see their GP again. From time to time, the GP wouldn't be able to cure them, so we'd send them to a clever doctor who would give them a different prescription or cut off the offending article, and they'd be back to normal life. And then at some later date, they might need the NHS again. Reality now is that these patients, who already account for about half the workload of the average GP practice, don't have a problem, they have several problems, and they're not curable. And they don't stand alone. Many of them are so interlinked that it would be unethical to treat them in isolation. And these are people who don't need more and more of what we started off with. They need the kind of things that by and large only we in the community can provide. They need expert generalism. They need a holistic, not a specialist approach. They don't need their heart taking in isolation of the rest of their problems. They need a whole person approach. If it feels like general practice is getting more and more busy, this is one of the reasons, and it's to do with the people we serve. And the reason why I think that's important is that it's not just a pressure on us. I think it points to some really important opportunities. for us. And I know the ones that you've been looking at, and I think I'm going to really just sort of preach to the converted in saying I think we need to grasp this reality ourselves as commissioners or as providers, and ask, well, what could we do to really do very much more and very differently to do things that will help the pressures and to help us realise some of the opportunities. So let's go back a little bit to the pressures, because they are important and it is sometimes hard to get past them as a barrier. The general practice forward view. Has anyone had a chance to read the whole thing? Very good. Well done, 6 people. Seriously, well done. Someone told me off last week for apologising for it being long, because they said the reason it's long is there's a lot of stuff in there and no one's really put a lot of stuff in for general practice. And I kind of get that. Apologies that we haven't yet done a really great, quick summary. Loads of people have tried. I'm going to try and show you a quick summary now, and you can tell me afterwards whether it's any use. I suspect it's all right. The general practice forward view is an attempt to bridge the current pressures, which are real and urgent and we have to deal with before we move on, and some ways of moving on that would not just make us more sustainable but actually probably do a better job for our patients and make our organisations more sustainable, and I think address some of the frustrations GPs as professionals, as individuals have been feeling for a long time. And there's an extent to which it's sort of the implications of the whole system forward view for us in general practice and the people that we work with. And it looks at 5 areas in which there's national action that's going to be taken for us. Acknowledging that actually a lot of the things people describe as being wrong right now, a lot of the places we'd like to get to that are too hard right now are not of our own making, they're nothing to do with us, only the national system could help. So these areas around investment, workforce, workload, infrastructure and supporting and accelerating care redesign are all intended to help simultaneously make us more sustainable by taking pressure off us and build our capability to move forward for the future. A different way of seeing it, and this is what I'd love to know at the break, whether you think it works. And apologies that the text is now quite small. There was so much to squeeze on the screen. Breaking it down, if you've not had a chance, and if you're wondering how on earth you could read a 66-page document, if you flick through it and look at just the bold bits, that will give you the headlines. And there's going to be a paper copy in this month's Pulse, but you can also get the PDF online if you just Google forward view or go to england.nhs/GP. You'll get it. So there's some stuff in the short and medium term about stabilising practices, resilience teams, the stress GP service, doing much better for our occupational health and core investment. Core investment, the plan is it's going to go up in sort of cash terms by 25%, but if you account for inflation, that's 14% between now and 2020, which is faster than the rest of the NHS for the first time in a while. But there's other stuff as well about managing demand differently, staying well, self-help, signposting, a lot of things about streamlining things, so making medical records, prescribing referrals smoother for us, sorting out GPs and GP to GP payments and transfers, changes to the hospital workload, lots of things about NHS England, CQC, the GMC and CCGs, asking for one piece of information once, which would be nice. The Time for Care development programme, helping people to improve access without just working longer or harder. Minor ailment schemes, social prescribing, virtual wards. And then lots of things that are going to take longer, many of which fall into the really big chunky categories like workforce, more GPs, more nurses, getting pharmacists in, mental health workers based in the practice, those sort of things, where people have started, but growing new people in the workforce is always very, very slow. So some of these things we're not going to feel, well, some of us will, but most of us aren't really going to feel the benefit of that in the next year, definitely. But there's an awful lot of stuff in there, and I would really encourage you, if you haven't had a chance to flick through, like I say, if you read the bold bits, They do give you a pretty good view of the headlines, and it probably only takes about 10 minutes doing that, depending on your reading speed. And the idea, like I say, is partly to help right now, and partly to do some stuff that's different. So here's an alternative view, which begins, and I think, picking up on your local vision as it currently stands. This may start to give some ideas about where you'd like to add more detail, and where practices might like to sort of take the lead on some new stuff. Here are the kind of pictorial representation of the things being planned in the forward view. So right at the heart of the practice, some increased investment and support and kind of practical help for just day-to-day survival, helped by some changes to regulation, indemnity, payment systems and things like that. At the patient end, quite a lot of new things being done to try and reshape demand and help people and populations take more care for themselves. At the secondary care end, quite a lot of work to try and partly help hospitals do more of what they're responsible for and contracted for, rather than it fall into general practice. But then actually asking how can we work in better collaboration, which might free up time and might improve care, and probably will do a bit of both. Asking very similar question about out-of-hospital things in the community, and then how could greater support be given for people to work collectively in practices. And I think what's really interesting about that is it starts to put a bit of maybe practical idea on what it could look like if we were to not just help right now, but to help in ways that would build for the future. Because actually, people are, or have been for a number of years, looking to a slightly different future, and saying what we've got in general practice right now is brilliant and worth being proud of, but there are ways in which we've been wanting to improve it anyway. I'd like to sort of kind of now focus on what those might look like in practice for you. Lots of people actually have been looking forward for a long time, and I sort of was slightly flippant about criticising our focus on structures and forms earlier, calling it a red herring. I think it's a red herring until you've answered this question: what kind of care do we want to provide for people that we serve? That's why we get out of bed in the morning. That's why I went through medical school and did all that hard work. It's to deliver great care. And I think what's been really interesting in the last few years is that people have been saying, fundamentally, the contribution of primary care is vital in the NHS. So people are all working towards, if you look at, I get the privilege of seeing lots of people's strategies and their plans and the kind of things that they're working on for the future. And you can sum a lot of it up by saying people really value the idea of comprehensive, joined up care for a registered population shaped around them in the community. Lots of people are reaching towards that vision. And most people are saying, in order to do that, make it a reality, there are probably 3 things about general practice which we need to release more of the potential, rediscover, beef up. One of them is our focus on well-being, prevention and promotion. We're not just here for when people get ill. Secondly, doing access, but not access defined as being just quickness, but actually the right access at the right time to the right person, recognising that patients don't all have the same need. And then thirdly, building on that last point, actually for folk with long-term conditions or at end of life, we want to be delivering more of the potential we have for holistic, proactive, coordinated, kind of team-based, multidisciplinary care. Not just always medicalising, not just always meeting a rise in demand by me prescribing more mirtazapine, but actually doing what primary care does really well when we're liberated to deliver our potential. And I think, it's a small aside, but I think it's an important one, that will help us with 2 areas of frustration right now. And what's really helpful, I'm glad that you've been talking to Local Health Watch, is that when you speak to patients about what they think could be improved, it's almost always the same list as when you speak to GPs. Not always, and not always the same priorities, but the 2 things that patients think the NHS needs to improve are access, particularly to general practice, and the disjointedness and disintegrated care that they receive if they've got a long-term condition, and heaven help them if they've got 3 or 4 or 5. And actually, a lot of what you get when you speak to GPs is, We've got this real problem of appointments and growing demand, and we can't provide the kind of access that I want to because it's all too hard, and a lot of it's inappropriate and it shouldn't be coming to me anyway. That's one of the big things GPs feel aggrieved about. And what's really interesting is that comment from patients. They don't want to bother their GP, but if there's no one else around, what do they think they're expected to do? But same about join up. You know, it annoys us as well as GPs, particularly we're kind of in the middle, supposedly coordinating what is essentially a disjointed system for the patient. And it wastes time, it wastes opportunity, we kind of get to the end of the day feeling we've been firefighting. So if you look at that, it will help us, I think, with a lot of the shared frustrations. So what could be done to make some of that a reality? I think from our patient's perspective, we're kind of talking about doing a great job of access, but not just more of the same. And this is something I find myself saying a lot to people. If you think about what kind of care, it's taking some of the things we already do really well, some of the things we wanted to do well when we first came into this, but aren't doing enough of at the moment, and concluding that it ends up looking a bit different in some ways. And this is one way that we're illustrating it at the moment, and I hope you find this sort of illustration helpful. It's saying that at the starting point, we need to be far more focused on well-being and empowerment before people get care, and then what kind of care they get should be different in some interesting and maybe quite specific ways. So on well-being and empowerment, you know, we do care about this stuff in our practices, but we've been a bit focused recently on just getting more and more skilled up for more and more specialist treatment. And actually, what does it look like? And there are people already who are working as groups of practices, particularly with others, to say, how can we do more for our patients on helping them keep healthy, look after themselves, use other people, and connect with not just medicalised support or treatment, but actually other sources of care and support in the community. When people do contact a practice, a lot of folk are asking about how we can respond to them in a way. It doesn't just say, hello, when can I book you an appointment with a GP? But hello, what do you need? Who's the most appropriate person to help you today? I'll connect you with them, and that will sometimes be a GP, but not always. When people are having consultations, lots of folk are doing new ways of consulting, some of which improve patient experience, some free up time, some hand more responsibility to patients themselves, and a lot of them are so that the bottom line is when you have a face-to-face appointment, you've freed up more time for the GP to have, you know, more than just 10 minutes with someone, which would be lovely. Making that a reality means actually we need to have a bigger idea of what our team looks like. And again, I know you're doing some of this already, and I think it's the right thing to be focusing on broadening the team, so it's not just more of the same we're talking about, but it's a broader and more diverse offer for patients, and one that's making use of some of the points about appropriateness, which I think are a bit awkward, but I think very important for us. And then lastly, and this is probably just about access, people are acknowledging that there are two different types of need on the question of access. Some people need quick care, some people need continuity, and there's lots of overlap between them, but actually you could design a way of meeting people's needs that would incorporate all of that. And so when you put all that together, what kind of vision are we talking about for the future? Well, it's kind of like general practice and it's kind of not. It's kind of about building some things that we do well, and in some respects giving away some of what GPs currently do that they think is inappropriate, that other people could do better. And I think it's also about looking outside the boundaries of the practice itself. And that's why I think it's sometimes challenging, because our visions for general practice are often not really just about general practice, they're about the bigger system as well. And that can feel very threatening, particularly I think to GPs and maybe slightly lesser extent to practice nurses. But if that's our vision for the future, I think we can start moving on it. I don't think we need to wait. And my challenge to you is going to be, don't wait, start somewhere and start soon. I'm going to suggest some ways in which you might start soon. I'm going to share very quickly a set of ideas that we've gathered from practices who are already making change happen. and you might want to scribble down one or two that you'd like to learn more about. I'm going to show you a website at the end where you can see an awful lot more about them. We're calling these the 10 high impact actions to release time for care. And I know some people have had the opportunity to see it already, so I'm not going to kind of labour this, but you can read more about it in the General Practice Forward View, and like I say, I'll show you a website where there's loads more information later on. What a lot of practices are saying at the moment is, it's good that somebody else is going to help us. It is good that somebody else is going to reduce bureaucracy or take away some of the stuff that comes to us inappropriately from elsewhere. But there are some things that lie just within our remit. Things about how we work. All of those things are highlighted in green, which account for maybe 2,000 appointments a year for many GP practices, are in our hands, and we could do things differently. Not just have more of the same, we could work differently and simultaneously free up some time and do a better job for our patients. What will that look like in practice? Well, let's have a very, very quick trip through what these things are. Active signposting is what I mentioned earlier, where we kind of quite active about saying, who's the best person to help you today? How can we help? How can we direct you appropriately? And that's partly about getting you to see the right GP, and often about saying, you don't need to see the GP for that. We could get you somewhere else, and you can do that whether you're online or actually in the reception. Next, when people are having consultations, as we see, a lot of the new consultation types have come from people wanting to provide more convenient care, or the text messaging group consultations have come from people wanting to improve self-care, but actually they all look like they free up time for GPs as well, the biggest constraint in the system. Next is actually a lot of people are realising that there's an evidence base. Hands up if you've done something to try and reduce DNAs in your practice in the last couple of years. Yeah, it's virtually all of us. We've just started our latest attempt to do something about DNAs. And you know what? There's an evidence base behind it. And there are things that work and things that really don't work very well. And we could share some of those examples. So on this website, you'll find examples of that evidence that will guide us a bit better to what works best. There are also a growing number of real examples, not just hypotheticals, about what people could do in the area of developing the team. What would it look like for us to have physios accessible on EMIS to book into for the receptionist? What would it look like to work with pharmacists, either in the practice or in the community pharmacy? People have gone from beyond just talking about it now to actually doing it. And there's a growing number of case studies, people sharing their own experience, their own tips about that. I think we're really bad in the NHS about sharing our experience, and it's time to get better. A lot of people are saying, do you know what, just the way that we work, the way we organise our work could be improved, and people are discovering the power of looking at those sort of things systematically. And there are some good case studies emerging of what people achieve when they do that. A lot of people are looking very much more personally and saying, do you know what, we could free up some time by some really prosaic things. I speak to a lot of practice managers who say, you know, in cough fever season, January and February, when I give out my list of patients that GPs got to review, I can tell you the GPs will take 10 hours over that, and those will take 15. And the big difference seems to be that some of them know the tips and tricks on the computer, and others don't. And some of them read quickly, and some take like 3 times longer to read a list or a letter, and some type quickly, and others don't. And we could free up some time, and people are sharing their examples already of how they're doing that. Partnership working has been, I think, regarded by many of us as very attractive for a long time, but an add-on. And I think increasingly people are using their federation, or a new partnership with secondary care, or a new partnership with the community trust, or with the voluntary sector, to simultaneously do a better job for patients and free up some GP time. If there's somebody else around here who could do a good job for this patient, why don't we partner with them and see what it would look like? And people are starting to share their examples of that as well. And the last 2 biggies, social prescribing. One of the biggest complaints GPs have about their patients is about the appropriateness or not of some of the needs that are brought to them. One of the things that makes GPs most likely to feel angry towards a patient is when it's something that I can't help with because you're already taking the maximum of every medication I know. And that's not the patient's fault, but we do often feel angry about it. It's one of the big things that comes up in mailing groups. But actually, increasingly people are discovering what it looks like to practically do social prescribing, and there are lots of different models of doing it, whether that's having people in the practice or having an external service you refer out to. There's some really great examples and practical tips people are sharing about doing that. The same as for supporting self-care. We were chatting earlier, I'm delighted at how much you're already doing in Bristol on this. And people are increasingly sharing their own examples about whether it's prevention or handling acute episodes differently, or helping people live with and manage their long-term condition differently. A lot of things could be done by patients and their carers together. And then lastly, when you look at some of that, you think, whew, interesting, but how would we do it? Well, a lot of practices are already discovering, or federations are discovering, that you can build your change leadership, or your QI, quality improvement expertise, and it enables all of the others without just working harder. There are ways of working smarter. That was perhaps the quickest run through I've given of 10 completely different sets of ideas. The important thing, the reason why I wanted to share it with you, is to encourage you to have a look at what other practices around the country are already doing to make this a reality. So together with the BMA, we've started gathering these examples from people, and we've started taking them out on the road and sharing them. As a means, really, of helping all of us to learn from what others have found useful. What I think is amazing right now, the place that we find ourselves in, is that when you look at the pressures and you look at the opportunities in the new kind of innovations people are testing out, they are so often in exactly the same place. That introducing one change could help us release some pressure where it's most painful, which is, for most practices, it's in GP time right now. And at the same time, we do a better job for the patient and for our community of patients. The other thing I think is really important about it, I know that you're thinking a lot about working at scale and what that would look like in practice. I think what's really interesting is that you look around this list of 10 ideas, and a lot of them you could do as a practice, just on your own. But an awful lot of them would work way better, and it would be easier to actually do the process if we were doing it collectively, either with other practices or with our community pharmacy, with our community nursing team, with other therapists, with the voluntary sector. I think we're at a time when many of the same solutions will help multiple things if we go about them the right way. And one of the questions I'd like to leave you with is, which of those you think would be most useful for you and your practice and your patients? That has been a massively fast canter through loads of different things. I hope some of it's been useful. I'd like to leave you with a challenge which I think will help us as we kind of move through a bit of a discussion, and we're going to have a break and a table discussion about, so what now? I think the question is, so what now? And I'm glad that you've sort of set yourself a big challenge. I think for us, what now? I think we need to focus on service as well as survival. Not just addressing the pressures, but actually building something better for our patients. I think we need to just sometimes throw away the angst of coming up with big strategies and making sure they're utterly, utterly perfect, and that we've mapped out the whole of the next 20 years before we start. I'd encourage you to start with what you've got, which is a group of people who are really passionate already and committed. Start with who you've got, start with what you've got, and do something together. And making that happen, I think, sometimes means starting with the partnerships that exist already and building them as you go along for the future. And the next thing, I think, is be alert to the capabilities that you will need to make that happen. And then finally, build the structures, the contracts, and all the rest of it that will sustain what you've already started doing that's working well for you and your patients. I think we know enough now to get started. I think there are enough practical ideas that would help our practices survive and would improve access and improve the appropriateness of access and deliver some enhanced care for people so that they can take more care for themselves, lead healthier lives, and they would build partnerships for the future that, you know, whether you end up being an MCP or a federation or one Uber practice or something that looks nothing like any of those, actually you're just doing a better job and things are more sustainable. The general practice forward view is going to do an awful lot of stuff from outside that will make it easier, more money, more people. But I think the responsibility for us as practices is to say, let's not just use that to do more of the same. Let's ask what we could do differently as well. And I think it's time, because I think we've got the examples and the evidence now, that we can have confidence to say, okay, shall we agree as a locality, we'll pick 2 or 3 things and we'll try and do them together over the next couple of years. And we'll build our relationship, we'll build our federation, we'll build our partnerships with lots of other people along the way of doing that. And I said that I started a lot of my career looking at whole systems work and integrated care. What's really nice is that what I've just described I think will work for us as practices. But actually, the big lessons from the evidence about successful whole system change and integrated care are: start with what you've got, build the clinical relationships around the patients as you improve care together, and let the structural stuff serve that. So I think it will help us, whether your burning passion today is to survive the next year, or to make the practice more sustainable, or actually you've got a burning passion to do something differently for the population and the community you serve. I think some of the practical ideas I've just run through very quickly could help with all of those. So I'm going to stop there. Thank you. Good luck. I'm going to go back to the first slide with my email address and say I hope to stay in touch with you over the next few months and years as you kind of start making it all a reality. Thank you.